me and inviting me, Louise. It's lovely to be here on a pleasant morning. It's not raining for a change, so that's really good. Got a bit of gardening done this morning, so I'm feeling invigorated. And thank you for the introduction. It was obviously need to trim that back a little bit. It was a bit too long. I'm really excited to be able to talk about continence, because obviously you can tell from my background that I've had a long history working in the field, and I really think that I have been very fortunate in my career to be able to help improve people's quality of life with regard to bladder and bowel issues. So, you know, even though we might not be able to cure everyone, a lot of people we can definitely make feel more comfortable and more confident. So I'm going to go through a fair bit today, and at the end, if you want to interrupt me if you've got some questions. So just sort of hopefully giving a spin on what's typical, and then, you know, what are the resources around, and also a little bit about the Continence Foundation, the organisation I work for, which is the peak body for bladder and bowel control health. So thank you. I'll get going. I would like to start off with an acknowledgement of country and acknowledge the traditional custodians of the land of which we are meeting today, and pay my respects to elders past, present and emerging. So as I mentioned, the Continence Foundation is the national peak body for promoting bladder and bowel health. So we've been in existence for, I don't know, about 40 years now. We do a lot of advocacy and promotion with regard to continence in general. We have a lot of resources, which I'll discuss at the end of this presentation, including the National Continence Helpline, the National Toilet Map. So there's lots of information around that the general public can access with regard to continence, and hopefully get some advice and information. So our vision is to have a community free of the stigma and restrictions of incontinence, and as I mentioned, the support information and resources that we have and create and continue to constantly evolve, that are available for individuals, carers and professionals, health professionals. So what I'm looking at now today is information on incontinence, continence assessment, continence products, healthy bowel habits, and also bladder and bowel habits, and also what help is available. Sorry, I'm inclined to talk quickly, so tell me to slow down if you need to, because I'm always in a hurry, got a lot to say. So I'll try and be a little bit conscious of that. So when we talk about continence, it's the ability to choose the time and place when you want it, where you want to pass urine or pass a bowel motion. So you shouldn't have to just stop on the side of the road and go run to behind a tree, for example. You know, you should be able to hold on until you go to a socially acceptable place, be able to painlessly and comfortably pass urine or pass a bowel motion. So that's what's considered to be continence. So on the flip side, incontinence is the accidental or involuntary loss of urine or a bowel motion. So when you just can't get to the toilet in time, whether it's because you're physically unable to get there in time, or there's barriers preventing you, or is there's something happening with your bladder or your bowel and the supporting structures that interrupt that ability to hold on and get there in time. So it is a common problem. So just to be aware that it affects over 5 million Australians over the age of 15. Sorry, I'm just going to move something up here. And that in the general population, you're looking at 1 in 4 people have a continence issue. So it is quite extensive. And if you've had a baby, us ladies who are present, we've got an increased risk of 1 in 3 women who ever have a baby will experience incontinence. And you probably are aware, even though it's not an aging condition, as you get older, you can collect more conditions that might increase your risk of incontinence. So even though women might be more prone to incontinence at a younger point in age, men are inclined to catch up by the time we're all of an older age. And 1 in 20 people have problems with bowel control in addition to that. So I think sometimes we think more about urine, but you probably know, especially with scleroderma and the impacts on the gastrointestinal system, it can be quite a significant issue if you do have problems with bowel control. And it's probably more challenging to your comfort if you do have a bowel control issue. Oops, sorry, go to the correct screen. So what's normal when it comes to bladder and functional control? It's normal to go to the toilet about 4 to 6 times during the day. You might find you have to go a little bit more when you're older, but you shouldn't be going more than sort of 8 times a day. It's normal to go once or less at night. As you get older, it might be 2 times or less at night, in a typical 8-hour night, that is. You shouldn't have to rush to get to the toilet. You should be able to hang on. And especially with bladders, it's actually okay to hang on a little bit. So it shouldn't be that as soon as you get an urge to go, you need to go straight away to the toilet. You shouldn't constantly have you shouldn't constantly be needing to go, so going back and forth, back and forth. So it shouldn't be that every 5 minutes you're needing to go back to the toilet. You should have a good emptying of your bladder and you shouldn't have to return. You should have no leakage at all. And I think sometimes, particularly women, think a little bit of a loss when you have a little cough is normal. Well, that's not normal at all. So you shouldn't have any leakage or experience any leakage at all. You should pass about, if you really want to measure it and you're really keen, you should pass about 400 to 600 mils each time you go. So that's sort of like 2 cups or a bit over 2 cups of wee. You know, if you think about a normal decent sized cup, is about how much you should be passing. And the bladder comfortably can hold about 600 mils. So sometimes it's worthwhile if you think, oh, something seems, I feel like I'm going a lot. If you want to take a few measurements, it might give you an insight into how much your bladder can hold. And maybe that gives you a sign that maybe something is happening with your bladder. And you should have less than 50 mils left behind after you have a wee. So that's more when we do ultrasounds, we can check how much is left behind, because you want to empty as much out as possible so you've got plenty of space to fill it up for the next time you need to go to the toilet. So you should empty well. And also that decreases your risk of infection, because you don't want stale or old urine sitting behind after you have a wee. You should have a good stream. It should be strong and continuous. And I'm a bit obsessed now that every time I hear my husband weeing, I'm always listening to his stream. But it should be a constant stream. It shouldn't stop and start. Once you go, it should just flow nicely. You shouldn't have to wait a while to get it going. As soon as you sort of sit down and relax, the flow should just come out nice and easy and constantly. You should have no trouble starting, and you shouldn't have to be turning on taps, or you shouldn't have to be doing any sort of other activities to try and get the wee happening. As soon as you're relaxed and sitting on the toilet, it should happen. You might find that you can get a bit of stage fright in a public toilet. So say if someone's in the cubicle next to you, sometimes you do tense up a little bit, and that's probably a little bit different. But in your own home, you should be nice and relaxed, and it should just flow out very quickly, and you shouldn't have to wait. There should be no after dribble or leakage after you leave the toilet. So once you've had a wee and you've wiped yourself and you get up and stand away, you shouldn't leak any more urine. And I suppose this is probably more something you see with men more than women, but women can experience that too. That after you finish having a wee, you stand up if you're already standing, you shake and you walk away, and then you can leak a little bit into your undies. So that's not normal, but it is not uncommon. But there's things that can be done to improve that. You shouldn't have to strain or push to have a wee, and sometimes people don't even realise that they're doing this. So just be really conscious next time you go to the toilet that you're nice and relaxed. You're not pushing or bearing down on your tummy to get your wee out. It should just be flowing nice and easy. You shouldn't have any pain or burning when you have a wee. So it should, again, be comfortable. Sometimes it's the only time you relax is when you actually sit on the toilet, because you can shut the door and take a few deep breaths and just relax. So it should be a lovely, relaxing time when you pass your urine. And you should feel completely empty. So after you have a wee, you shouldn't think, oh, gee, I feel like there's something left behind. You should feel nice and comfortable and feeling like everything's come out. And you should be able to hang on until you get to a convenient place. So it shouldn't be a thing that you have to leave your shopping trolley in the middle of the supermarket and go rushing to find a toilet. It shouldn't be that you get home and you have to go rushing into the house to get to the toilet. And we actually call, say, people who do need to rush when they get home, we actually call that key in the door. So it's it's not an uncommon thing that people are fine, they've left the supermarket or they've left their friend's house, they come home, they see their front door, or they arrive into the garage and suddenly they need to go to the toilet. So again, that poor bladder control, you may rush, you might have that leakage, you might have to go a lot during the day, and you might be waking up more than twice overnight. And I mean, I work on the National Continence Helpline, and some people can ring up and say they wake up, 8 times overnight to get to the toilet, which is exhausting and tiring and can increase your risk of falls. So, there's things that can be done to hopefully improve that. So don't put up with those those symptoms. And then also be aware that there's different types of incontinence. So it's not just incontinence. For example, stress urinary incontinence is when you cough and sneeze and you leak, and there's stress on the neck of the bladder or the pelvic floor. An overactive bladder, an overexcited bladder, which is not uncommon with people with scleroderma, is when the bladder suddenly wants to empty very quickly and you need to rush to the toilet and it's hard to hang on. Overflow or urinary intention is when you don't empty your bladder well and you might leak a little bit and just get a bit out. But it can sort of seem a little bit like you're rushing and going frequently, but it's a poorly emptying bladder. And then functional incontinence is when you physically, mentally, or environmentally can't get to the toilet. So say if you struggle to walk to get there, or you don't have the proper equipment in the bathroom that you're trying to go to, or you might have dementia and you can't actually find the toilet by yourself. And you can have, as I said, a combination of these things. So someone could have stress urinary incontinence, overactive bladder, and functional incontinence. And so it's not just a simple thing, I've got one of these things. You could actually have a few of these things. So that's why you really need to have a really detailed assessment and get some good advice if you do experience some incontinence problems. So when we talk about scleroderma, you probably are aware that it can affect the lower urinary tract, and some of the more common signs and symptoms that a person with scleroderma might experience is frequency, so going to the toilet often, urgency, going in a hurry, nocturia, going at night, also getting up to the toilet at night. So the bladder might not be contracting, or should say contracting more rapidly and causing you to need to go to the toilet in more of a hurry. And you might struggle with your pelvic floor muscles and other supporting methods to actually settle that bladder down and be able to give yourself more time to get to the toilet. So when it comes to bowels, it's normal to go to the toilet anywhere from 3 times a day, I shouldn't say on average, 3 times a day to once every 3 days, and somewhere in between. There are people that might find they do go less than that or more than that, and that might be still their norm. But typically, this is what the typical pattern is. I think the most important thing to really look at is what comes out. So you should be passing a soft formed bowel motion. So I occasionally have people who say, I never look. Well, please look. It is quite useful, that information. So it's good to know what you pass in the toilet, and do have a look at what your bowel motions look like. There should be no leakage of solid, liquid, or gas. So you should be able to hold your flatus in. And if you can't, that is also a type of incontinence. I know my grandmother couldn't hold hers in, and she didn't seem to worry too much anymore, but she did have 11 children and lived till 102. So she was happy letting her gas come out all the time. But it is still not normal. So just be aware that if you do struggle to hold your wind in, and also, that if you've got diarrhea, and that can be even more challenging, and also a formed bowel motion, you should be able to hold that all in. And so when we look at, if you've probably seen this scale before, particularly if you've ever been in hospital, we often use the Bristol Stool Form Scale, and it's the optimal or the best poos are type 3 and type 4. So that's what we sort of aim for someone generally to have, is one of those types. Type 5 is not too bad also, but if you're passing a type 1 or type 2 stool, that probably indicates you might be a bit constipated. Or if you're passing a type 6 to 7 stool, it could mean that your bowels are a bit loose. And it also could be a sign that you're very, very constipated as well, and you're getting some loose bowel action past a hard bowel motion. So preferably you sort of aim for a type 3 to type 4 bowel motion. You shouldn't have to rush to the toilet to use your bowels, so you should be able to hang on. So it shouldn't be that as soon as you have that urge to go, you do need to go in a hurry. You shouldn't have to excessively strain or push to pass a bowel motion. You might have to increase some of the pressure in your tummy when you do a poo, but you shouldn't have to be really straining and pushing very hard to get that bowel motion out. You should feel like you empty well. So you shouldn't feel like, oh, I feel like I've still got something behind. I'm not really comfortable. I think I need to go back again. So when you go, you should have no feeling that you haven't emptied completely. And you should have no pain on passing a bowel motion. So it should be really nice and comfortable when you do a poo. It shouldn't be a lot of discomfort and a lot of, feeling really sore. So poor bowel control, again, is the opposite. So when you have accidental leakage, and we talk about leakage before you need to go to the toilet, so you leak on the way to the toilet. Some people leak after they've gone to the toilet. Some people leak without awareness. So again, these are sort of important bits of information when we do a continence assessment. We try and find out the situation of the leakage. You shouldn't be soiling on your clothes, so there shouldn't be even a smudge on your clothing. You shouldn't have to strain, and you should be able to control wind. So again, there's lots of different types of bowel conditions as well. So you're probably well aware of constipation. Fecal impaction is a severe form of constipation, and that's when you get that liquidy diarrhea might come past a very hard stool in your bowel. Diarrhea, I'm sure you're well aware of. Fecal urgency, so needing to rush to the toilet, which might be related to a loose bowel action, but it also might be related to your bottom or your anal sphincter and your pelvic floor muscles, which are the holding on muscles that you use to hold things in when you need to go. Again, functional incontinence, like described with the urinary incontinence, when you can't physically, mentally or environmentally be able to get to the toilet. And then defecation dysfunction or difficulty emptying, which might be a little bit relevant to scleroderma, is when you can't empty your bottom well, or there's a bit of discoordination between relaxing your anus and your pelvic floor muscles and how you use your tummy, and actually having a good emptying technique and a good positioning on the toilet. So again, it's always not quite that simple always, and you can have a combination of these things as well, that you might have to rush to the toilet because of problems with your bottom, but then you might not empty well because of other things like prolapse and changes in anatomy. So again, it's not just a simple thing, and that's why a good assessment can be really helpful. So scleroderma, as you're probably aware, can have quite a significant impact on the digestive system. And you're also being aware that, the gastrointestinal system is a long, hollow muscular organ that starts at your mouth and ends at your anus. So it's a very long tube where there's lots of different spots where there can be some changes. So it can cause diarrhea, particularly when it affects the small bowel and affects the movement within the small bowel, where a lot of the breakdown of solids happen. And then it can cause constipation, and that might be more relevant to the large bowel, because in the large bowel, that's when we absorb water out of the bowel motion to sort of equilibrize ourselves or make sure we have enough fluid within our body. So that's where the poo becomes more formed. But if it's in there longer or doesn't move as quickly, you might end up with constipation. I mentioned the defecation dysfunction, so the problems with coordination between sort of relaxing muscles and positioning on the toilet and emptying your bottom well. So that might be an issue as well. And then fecal urgency. So particularly if you've got diarrhea, you might have to rush to the toilet. You might struggle to hold on. So it can be challenging. And the bowel movement can slow, and the passing can be difficult. So it's sort of, again, a combination of those sort of things can happen when you experience scleroderma, which I'm sure you're even more informed than I am. So some of the risk factors for incontinence, because again, I gather you might have scleroderma, but I can see quite a few women in front of me who've probably had children as well and gone through menopause. And so again, it's not just this one thing that might have an impact. It could be multiple things. So being aware that pregnancy and childbirth can increase your risk of incontinence. Menopause can increase your risk of incontinence. Being overweight, we've already mentioned constipation. Numerous health conditions can increase your risk of incontinence. So, stroke, multiple sclerosis, Parkinson's disease, spinal cord injury. So there's numerous health conditions that can increase a person's risk of incontinence. Medications, if you've ever taken antibiotics, that could increase your risk of incontinence with diarrhea. If you've taken painkillers, that can increase your risk of incontinence with constipation. So if you ever look at the side effects of medications, most of them mention some sort of bowel impact. There's also ones that can affect your bladder, such as some antidepressants can actually cause you to struggle to empty your bladder well. So there's lots of different medications that can impact on your bladder and bowel. Weak pelvic floor muscles, so even having a long history of coughing, so say if you've got a history of asthma and you have to cough a lot, that could weaken your pelvic floor muscles. Surgery, radiation therapy, chemotherapy can also have an impact on your continence or your bladder control. And so, for example, prostate surgery, can increase your risk of incontinence. Hysterectomy has an increased risk of incontinence. So there's lots of surgery, particularly pelvic surgery or abdominal surgery, tummy surgery, that can increase your risk of incontinence. And then radiation. So if you've had prostate cancer or bowel cancer, and radiation's been necessary in the area of the pelvis or the lower tummy, that can impact on your tissues and therefore affect your bladder and bowel. And smoking can increase your risk of incontinence, particularly with the related cough that might develop. So these are just some of the risk factors, but there's just so many conditions. And that's, again, why often having a good assessment can look into all these conditions and try and optimise or improve the situation as much as possible. So it's really important that you do see your doctor or healthcare professional if you rush to the toilet. And I know we've got a current campaign, the Continence Foundation, where we have posters in toilets. And one of the ones that we get a lot of calls about is that rushing, because I think a lot of people just sort of put up with rushing to the toilet and don't realise that there's things that could be done if you do find you do need to rush to the toilet. If you have any sort of incontinence, at least start with a chat with your GP. If you can't hang on, if you can't control wind, if you leak when you laugh, cough, sneeze, if you have trouble starting urine, if you strain to empty your bowel. So any of those things that I mentioned earlier, if you're struggling with any of those conditions, it's really good if you maybe start with a conversation with your GP to see if they can do some testing and investigation and start some treatment if this is occurring, or refer you on to a continence service or a healthcare professional. It's important, though, that you do seek immediate help if you suddenly can't pass urine. So particularly for people, say for men with enlarged prostate, sometimes they go into what we call acute urinary retention, where they can't wee at all. And that can be very painful. So they really need to present to an emergency department immediately. Someone who's had some spinal problems and suddenly can't wee, if they're really severely constipated and suddenly can't wee, you really need to go and seek urgent medical attention. If you're having a lot of pain and burning, so it could be a sign that you've got a urinary tract infection, and that really should be investigated and treated. If you're constipated and really struggling with your constipation, and if you've had diarrhea for more than a day, and it can be quite draining on you physically and increase your risk of falls and electrolyte imbalances. So we need to have lots of different electrolytes like sodium, potassium in our system to make our heart function well and feel well. So just really be conscious of you or someone who you care for experiences this, that they really need to see some urgent medical or attention. So a continence assessment, as I sort of mentioned, looks at the possible cause of incontinence, and it doesn't have to be incontinence. It can be just continence problems, like going to the toilet a lot at night. Is still something worth investigating, or rushing to the toilet. But you might not leak, but you might rush, or you might go a lot. So it's still worth having that investigated. And then coming up with a continence diagnosis, and then looking at the management plan or options to try and improve that situation. So the first step is to get assessed. And I think too, if most of the people on the call today, if you're based in Victoria, we do have continence services throughout all of Victoria, which are public continence services, as well as a lot of private services that are available. The public services are mainly based at the big rehabilitation hospitals throughout Victoria. I worked at the Caulfield one, and we do have nurses, pelvic floor physiotherapists, doctors, often geriatricians or aged care doctors. We had a urologist and a psychologist. So we do have a big team that works there that tries to assess and help people improve their bladder and bowel control. So some of the things that happen in an assessment is, we do a long list of questions about what happens on the toilet pretty much. Do you rush? Do you leak on the way? What does it feel like when you pass urine? So we sort of ask quite detailed questions of your experiences in going to the toilet. We look at your medications. We look at your medical history. We do some examinations and tests. So we generally like you to go and have a wee in a special toilet to look at how well your urine flows. We test the urine, check for infection, blood, any abnormalities. We do a quick ultrasound on your bladder after you have a wee to look at how much is left behind. And if possible, we'd like to examine you if you're comfortable with that. So feeling your tummy, looking at your legs and feet, and possibly looking at a vaginal and or rectal anal examination. So looking at your pelvic floor muscles, even if we can look on the outside, can be quite helpful to check for prolapse, check for muscle strength, muscle stamina, that type of thing. So that can be really useful. But, again, examination is very much personal, and it's really, you have to be comfortable with that, but it can be very useful to do an examination. Sometimes you need some continence products as well, and me as a nurse, we often will look at trying to find the right continence product to suit you, how to use that product, and also look at the financial assistance that's available in Victoria and Australia to help pay for the continence products, because they can be quite expensive. And with scleroderma too, if you've got skin problems and you're quite irritated from certain products, we can look at the options with regard to maybe lower allergy or washable products, or trying different types of products to try and see if there's one that suits you better. And particularly when it comes to disposable continence pads, the companies generally provide free samples, so you can try a few different options to try and figure out what would work for you and is comfortable for you. And you're probably aware of some of the continence products around. So some of them are disposable, like the two at the top, and others are washable, like the two at the bottom. There are a lot available in supermarkets and chemists, or else specialty suppliers, especially for the more absorbent type products that hold more wee. You often have to go to a supplier, a specialist supplier, or buy them online through a specialist supplier. So what you see in the supermarket is just a small taste of what is actually available when it comes to continence pads and continence products in general. So there is financial assistance around. Possibly one of the most well-known schemes is the Continence AIDS Payment Scheme. So that is a scheme available to permanent residents of Australia. If you've got an accepted diagnosis, you don't need to have a pension card. If you don't have one of the accepted diagnoses on the list, no, sorry, I didn't check to see if scleroderma is on the list, but I can do that before I leave. You need to have a pension card and then a certain bladder or bowel condition. There was also, and that this year, for example, the payment this financial year was $650.40. So it isn't a huge amount of money, but it is a little bit of a help for a person who needs to wear continence pads all the time. And there are also state and territory schemes. So in Victoria, there is the statewide equipment program, which provides washable continence products, bed protection, condom drainage, catheters. It doesn't provide disposable pads though, but it is, particularly if you do, prefer a washable pant, or you need some bed protection, chair protection, it can be quite useful. For people under 65, the National Disability Insurance Scheme can be a very generous scheme when it comes to continence products if your incontinence is related to your disability, and they can help cover all your continence needs. And for people who are veterans on a gold card or a white card that is covering their continence issues, that is also quite a generous scheme as well. So when you want to try and keep your bladder and bowels nice and healthy, just remember drinking well. You don't need to drink excessively, because I think we've gone from one extreme to the other where people drink heaps and heaps and heaps of fluid. Well, generally, if you're not on a fluid restriction, drinking sort of 1.5 litres to 2 litres a day of all your fluids is considered enough. If you're a bit more physically active, you might need a bit more than that, but then some people are on fluid restrictions. So you don't need to drink 5 litres a day, or some people think they need to drink 2 litres of water plus all their other drinks. So sort of be advised by your doctor if they're suggesting you do need extra fluids for a particular reason. But generally, having about 1.5 litres to 2 litres is sort of considered an adequate amount. You want to eat well, so eat a good, well-balanced diet. You want to be active. You want to work your pelvic floor muscles, and you want to follow good toilet tips, which I'm going to talk a little bit about. So drinking well, you sort of want to aim for that straw-coloured urine. Oh, it's going to be darker when you first have your first wee in the morning, but then it should improve later on in the day when you're able to have a bit more to drink. Be aware though that some medications can affect the colour of your urine, so it isn't as simple as just going, oh, my wee is dark, because I know my father, who's got Parkinson's disease, sorry, I'm just distracted by question, but got Parkinson's disease, as a medication makes his urine very dark coloured. Sorry, I'll just get to that question at the end if that's okay. Eating well, so a balanced diet of lots of different fruits and vegetables, fibres, because there's different types of fibre and they do have a different functions. So some is grainy fibre, some is gelling fibre, so it's good to eat a variety of fruits and vegetables. So you're normally looking at 4 serves of vegetables, 5 serves of vegetables, 2 serves of fruit, and plenty of whole grain breads and cereals as well. And we've mentioned the Bristol stool form chart, named for that type 3 to 4 bowel motion. Being active, so even gentle exercise can be important. So even if you can walk around the house and move as much as you can, also be aware that our bowel wakes up when we wake up. So it goes to sleep overnight. So you shouldn't really be needing to poo overnight, but when you wake up, the bowel wakes up, and then when you eat, the bowel is also woken up as well. So you try not to go back to bed straight after lunch. Straight after breakfast, because you've woken your bowel and you've stimulated your bowel with eating, and then hopefully that'll help you use your bowel. So do try and sort of keep moving for a little while after you've woken and after you've eaten, just to keep that bowel movement or that bowel activity happening, and particularly if you're prone to constipation. Work your pelvic floor muscles. So hopefully you've heard of your pelvic floor muscles, and both men and women do have pelvic floor muscles. And they come from the front tailbone to the front pubic bone, so the hard bit at the front of your pelvis, to the back tailbone or the coccyx. And for women, they support the urethra, the tube you wee out of, the vagina, and also the anus, so the bottom hole. And they then also support the organs above it. So they support the uterus or the womb, the bowel, and the bladder. So they have a really important job in keeping us continent, and also important of allowing us to use our bladder and bowel, because we keep them nice and tight when we're holding on, but we relax them when we actually go to the toilet. And for a men, obviously they only have the 2 holes, the one for the urethra and the one for the anus. But you can possibly see too, there is the prostate that sits just below the neck of the bladder, and that's why it has an impact on bladder control, because that prostate gland gets bigger in men from about most men from the age about 45 to 55, and it grows inward and outward, so it actually can start to squeeze on the urethra, the tube you wee out of, and a man might need to rush to the toilet more and go more often because the bladder has to work harder to get the wee out. Well, for us ladies, good old childbirth can have an impact on our bladder control, and it doesn't even need to be a vaginal delivery. Even a cesarean can have an impact on our pelvic floor and our vagina and our structures as well. I don't know if I'll just have to see if I think this is a video I'm just showing you. I don't know if you can hear the new noise at all. Can you hear that?
No, there's no sound.
Now, I probably can just play it without sound, but I'm not sure how I share sound on this. Louise, do you know how you share sound on this? Here we go. Call is being transcribed. I'm not sure. No. I can probably just present it with just the words, and you probably can see the movement. So I'm sorry. This is available on the Foundation's website, so you can look there. So
well,
I'm sorry.
Janie, we normally send a follow-up email, so
okay, that might be good if I just send those links in that. Yep,
that
great.
would be great. Yeah.
Okay, no
maybe
worries.
You can just talk us through it instead.
Okay, sure, no worries. Okay, so you can. So it's like a hammock that holds everything up from the front pubic bone to the back tailbone, and then it supports it back and front, side to side. And as I mentioned, it supports the bladder, bowel, and uterus, because they hold quite a lot, the pelvic floor muscles, and also supports sexual function. So they're important to have them working well, because otherwise you can increase risk of leakage with coughing, sneezing, lifting, and laughing, because they automatically tighten when you cough, sneeze as a natural reflex. But if you've got weakness, it might not happen so well. So to switch on the muscles, you need to squeeze and draw in the muscles around your vagina as if you're trying to stop the flow of urine. So all the ladies now, if they're sitting down, try and lift them up inside. So you feel this upward forward tilt. So it's a bit like a winking your eye, you're winking your vagina. If anyone can wink your eye, you'll feel the same sort of sensation. It's not a really strong squeeze, it's a very gentle squeeze. And make sure you relax after each squeeze. So you can see they tighten and close around the anus, the vagina, and the urethra when you squeeze them. So exercising them helps them to work automatically when you need them. They're also useful to know how to work them as well, because with certain conditions like that excitable overactive bladder, you can use pelvic floor contractions to manage that urge to go to the toilet. So not only is it good to exercise them, it's also good to know how to use them when you need to. Oops, sorry, don't want to do that again. Oh, so for the male, it's much the same. So also think about the pelvic floor as the base of the core. So we always think of the core as the abdomen, but the base of the core is actually the pelvic floor. So again, coming from the front pubic bone to the back tailbone and the sideward connection. So it's sort of this hammock that sits at the bottom of the pelvis. So again, same problems can occur, particularly after prostate surgery. Men are more likely to experience that loss with coughing, sneezing, lifting, laughing, exercising. So for men, they should actually think about pulling in the muscles from the base of the penis. So you actually think about imagining pulling the penis inwards. So you actually see the penis move in a little bit and the scrotum sort of curl up. So a man can look in the mirror and actually look for that action. A woman can also lay on a bed and put a mirror between their legs to look at that movement as well. And again, tightening the muscle closes the anal passage. And you can see that the testicles sort of move up a little bit. Particularly for anyone who has got some problems with leakage or worried about leakage when they're exercising, it might be worth looking at our Pelvic Floor First website. We've got a lot of pelvic floor safe exercises on there. So if you're a keen exerciser, but you are worried about problems with leakage when you do exercise or concerned about a prolapse, have a look at that website, and it goes through different exercises to sort of modify the way you do things just to sort of stop or prevent worsening of the problem, and also make you more confident when you do exercises and you're not going to leak or increase the risk of damage to the pelvic floor. Is quite a useful and practical website. Also important how you sit on the toilet. So particularly for a bowel motion, you should be nice and relaxed. You should, if preferably, lean forward with a straight back, elbows on your knees, tummy relaxed, and you should try and have your knees higher than your hips if you can. So that's the ideal way to actually go to the toilet. So just remember that incontinence can be managed, treated, and sometimes cured, and you can get help from your GP, your specialist, so a gynecologist, a urogynecologist, a urologist, a colorectal surgeon, a gastroenterologist, a geriatrician can all be helpful. Nurses like me, so nurse continence specialists, pelvic floor physiotherapists, so they're like nurses. We have postgraduate qualifications, experience in continence, so do pelvic floor physiotherapists. Pharmacists can be really useful. On the helpline, I often suggest someone goes in and gets some advice with a pharmacist. For example, say if you're needing laxatives, there's many different types of laxatives that have different actions, and it's often worth getting some advice on when you're choosing a laxative. And the National Continence Helpline. Now, So the National Continence Helpline is, I work on there 2 days a week and manage the helpline. It's run, or it's led by nurse continence specialists. We're available 8 till 8 Monday to Friday, Australian Eastern Standard Time or Eastern Standard Daylight Savings Time. We give free confidential advice. We can send out resources. We also give information on your local continence service. So if you are wanting to see someone, we can sort of tell you who your local services are. So it is worthwhile, even if it's a first step, just to start, start that conversation if you do have a bladder or bowel control problem. Hopefully we can at least set you in the right direction of where to next. And that's our number, 1-800-330-066. We also can offer a telephone interpreter service. So if you give us a call and say you need an interpreter, if we know the language, we'll call you back with that interpreter. Or else you can call the interpreter service first and they'll put the call through to us. We also have our website, so the continence.org.au website has lots of information on it, including resources. So if you want to, you can have information brochures mailed out, or you can download it straight from the website. There's so much information on that website. It's really good, worthwhile exploring and having a look at what is available. These are some of our resources. So brochures, we also have the Bridge magazine, which is a 4 times a year magazine on continence. That can be really helpful, and you can prescribe for that, and it's an brochure or booklet these days. We also mentioned the National Public Toilet Map. It's really useful to have that app on your phone if you're travelling, so you can find out where the local toilets are and what facilities they offer. And it can be really handy, particularly if you're travelling around Australia and you want to say, oh, I want to sort of plan my trip and I really need to know that there's some useful toilets, or there's toilets with disability facilities or whatever you need for your trip. Also remember, if you do need to access, some of those locked toilets that are on train stations, you can apply for a MLAK key if you haven't heard of one of those before, and that gives you access to those locked toilets. And I think it's a $20 a year, or I think maybe a $20 one-off payment where you apply for one of these keys and get your doctor to sign off on the form. If you just look or Google MLAK or Master Locksmith Access, otherwise look at the Foundation's website and you can sort of find out the information about the MLAK key. Where am I going time-wise? I might jump over all of this stuff because we probably don't need to do that. I'm running out of time. Sorry, Louise. I'll show you. Thank you. And I'm just going to quickly jump to that question, which I need to find. Okay, sorry. So the Continence AIDS Payment Scheme is an annual ongoing scheme. So you don't have to reapply. You only apply once and then it continues on. The only reason why you stop the payment is if you're on a home care package and the package provided pads through the funding from a home care package. If you ended up on the National Disability Insurance Scheme and they provided pads through your plan, or if you went into residential aged care and they have to provide pads through residential aged care. Otherwise, you don't have to reapply. Once you've applied once, it's ongoing. Each year, there's often a slight increase in the payment. So there's a little CPI or inflation increase each year. So from year to year, we never know what it's going to be. You can get annual or twice yearly payments. It's always a pro rata payment. So when you put your first application in, you'll get an amount worked out based on the number of days that are left for that financial year. So at the moment, if you put an application at the moment, you might get $350 or to $400 to last you until next July. And then the payment happens sometime in July. They never tell us the exact date. I'm just going to quickly check if I can